Okay, we can start now. Okay, so as we are saying that the congenital infection is itself a huge and a little bit broader topic, but anybody has any questions after that, our WhatsApp group is available. Our senior colleagues are there, so we can go together to understand these problems. Uh, okay, so I have to include these three, four infections. I purposely didn't include HIV and hepatitis C. HIV is itself a whole talk. If you are interested, if you know the prevalence in Pakistan and incident and how it is, uh, I can do it uh, one separate talk about only about HIV. But rest, I will go through it and then we will see what we can do. So in this talk, we will talk about tuberculosis, hepatitis B, torch complex, and the some varicella and herpes simplex, which is especially the varicella, that how we should go and follow those patients. So first of all, congenital tuberculosis. The incidence and the prevalence in Pakistan of congenital tuberculosis, not the tuberculosis, but the congenital tuberculosis, I couldn't find the latest one. So later in the discussion, if someone has some data, please share with us. The congenital tuberculosis is antepartum, which is in utero, intrapartum, and postpartum exposure. And it is more common than congenital tuberculosis. The postpartum one is the more common. The congenital is the risk of transmission is unknown, higher if the mother has primary disease. The postpartum is the risk to infant is 60 to 80%, and 30 to 40% if SPN negative contact. The pathophysiology is a very simple that it is hematogenous spread through umbilical vein. It is very obvious the livers, lungs involved, especially the liver and the lungs, these two organs, but other organs can also be involved. Aspiration, inhalation of infected amniotic fluid can be there, and the lungs primarily involved in in that scenario. Uh, Intrapartum, the aspiration, inhalation of infected amniotic fluid or infected genital secretions. So these are the old from the Lancet Infectious Disease Journal in 2008, but this is true till date, that risk of disease following primary infection. That let's say if somebody get the primary infection, then how much is the risk? So if a patient, if a baby get infection less than 1 year of age, disseminated tuberculosis and tuberculosis meningitis is about 10 to 20%. Pulmonary tuberculosis is about 30 to 40%, and no disease or chances of 50%. So 50% they can get the disease later on also, and the 50% chance there is no disease, and then so on and so forth. So that's how it is related, the infectivity of a patient. Now, clinical presentation typically at 2 to 4 weeks of age, non-specific, like bacterial sepsis, fever, respiratory distress, chest X-ray may be abnormal, hepatosplenomegaly is there. Additional is otitis media, drainage, lymphadenopathy, and cutaneous disease. So it is most common presentation in the congenital tuberculosis. The prematurity and the congenital tuberculosis, so affected infant often born prematurely. So if they get the congenital tuberculosis, the chances of prematurity is very high. There are multiple reports from neonatal intensive care units about that. The American Journal of Perinatology in 98 revealed that and two-fold greater risk of prematurity among a Mexican infant born to 35 mother with the pregnancy complicated by tuberculosis in the United States. So as I am discussing about the clinical features of congenital tuberculosis, these are the same. The common, the first one is very common, like respiratory distress, hepatosplenomegaly, fever, lymphadenopathy, poor feeding, lethargy, irritability, abdominal distension, failure to thrive, air discharge. So the frequency wise, the 76% is the respiratory distress, 65% hepatosplenomegaly, and 57% is the chances of fever. So if you have a triad of respiratory distress, hepatosplenomegaly, and the fever in a baby, please think about tuberculosis, and it is from the latest edition of Avery's Diseases of the Newborn. How you diagnose, how we, what we have, I will show you from the latest red book. Most of my references from the red book 2021. I think it is posted on our main group. If not, please WhatsApp in the main group. I will post it again. It's a reference in most part of the world, and I think we should have it as a reference in the Pakistan also. So the diagnosis of congenital tuberculosis, revised diagnostic criteria, the proved tuberculosis lesion, and one of the following. Lesion in the first week of life, primary hepatic complex or caseating hepatic granulomas, tuberculosis of the placenta or maternal genital tract, exclusion and postnatal transmission by through investigation of contact. This also published in New England Journal of Medicine. Now, how you evaluate for the congenital tuberculosis? So, the skin test is unreliable but helpful to have baseline. Interferon gamma release assay, I don't know if it is available in Pakistan or not. It has a very limited data. The chest radiograph, we should do it. Then mycobacterial confirmation by gastric aspirate, tracheal secretion, CSF, blood cultures. As I said, there is a chances of otitis media, so the otorrhea tissue and the drainage from there yield higher than for the older children. So this is the scheme which we are following here. Is the definition of positive tuberculin skin test results in infant, children, and adolescent, which is this one, that if you put the tuberculin skin test, which is TST in a short form, what is the meaning of that? In duration of 5 millimeter or greater, in duration of 10 millimeter or greater, and in duration of 15 millimeter or greater. So this is the key for that. Now, what is the algorithm? So let's say we are suspecting tuberculosis in a newborn. So we have to go through the pathway, which is age is more than 2 years. Uh, we will not go through this pathway, but age is less than 2 years, which is this pathway. So you have to put the TST, which is the tuberculosis test. If a negative result, testing complete, unless the sign and symptoms criteria met, then do the interferon gamma release assay. And then if it is a higher risk, high suspicion, and it is a positive test as per here, that how much is the end duration, then of course we have to go further and treat the patient. So you can go through it. I will send it this talk to Vikram to be posted to all of you. So the result of the diagnostic test, 29 infants with congenital tuberculosis reported from 1980 to 1994, published in the New England Journal of Medicine. And this is give you an idea that which test is more appropriate. So gastric aspirate, 8 out of 9, mycobacterial culture is 8 of the 9, and the smear of culture is 9 of 11. Endotracheal aspirate is 100% showing here 7 out of 7, and so on and so forth. So whatever the test you can do, whatever it's available there, you can try that and try to diagnose this disease. So I am showing you these different type of a test that don't go and don't wait that unless until you receive those tests, you should do it. But I think acid fast smear and the aspirates are available in Karachi as far as my knowledge. I don't know other part of the Pakistan. So how you manage of the newborn whose mother has latent tuberculosis infection? So the mother has reactive TST and normal chest X-ray. If mother is asymptomatic, no separation of the mother and infant is necessary. So there is no need to separate the mother and the infant. Mother should be treated for LTBI, which is latent tuberculosis infection. Newborn need no further evaluation. Household member should be evaluated for tuberculosis infection disease. So most of those infections are those which we are not separating and we are not stopping the breast milk. As I go through this talk, we will discuss about that. Now, the management of the newborn whose mother has suspected tuberculosis, mother has sign and symptom or the abnormal X-ray, then evaluate the mother, evaluate the infant for congenital tuberculosis. If excluded, then you have to begin isonize it. Separation of the mother infant until the evaluation complete, and if tuberculosis suspected until mother receiving the appropriate therapy. So only for that period of a time you can do that, and after that you will continue. And even that period, mother can express the milk. Once the INH is started for infant, separation no longer necessary unless mother has the direct tuberculosis or very coughing and all those, she cannot maintain herself. Isolation of the newborn if intubated or undergoing procedures involving the airway. Now, the management of the infant with postnatal exposure to the maternal tuberculosis. Okay, so the postnatal exposure. So then you have to determine the age of infant and duration of a symptom in the mother warrant evaluation for congenital tuberculosis. So the evaluation is the same. You can do the X-ray, you can do the TST, you can do the GA, induced sputum, CSF if warranted. If mother untreated, then separate until INH is started for infant. If evaluation is negative, then start INH, repeat TST in 2-3 months, consider empiric treatment for LTBI if repeat TST in infant would not be reliable in less than 6 months of age. So these are the general thing which we can do it. So the first table which I showed you is very important, that how to read the TST. What is the meaning of 5 millimeter duration, 10 millimeter duration, and how to read it. Okay, so please go through that table when I will send you this talk after I mean tonight or day after. So just keep it with you and then you will go through it. So if the baby has infection and you have to treat it, so this is the regime, the 12 weeks of INH plus rifampin once a week. These are the remarks. Or if you don't have, then 4 months of rifampin once a day, or 3 months of INH plus rifampin once a day, or 6 and 9 months of INH once a day. So whatever is easy, whatever you have it, you can do any one of the regime which is mentioned here. So these are those who are susceptible tuberculosis. Let's say you have a INH resistant tuberculosis, then you should use 4 months of rifampin once a day, and rifampin is easily available in Pakistan. If the baby has INH rifampin resistant, then consult a tuberculosis specialist. Then there are many drugs, and you are amazed that how many drugs can use linezolid, moxifloxacin, levofloxacin, streptomycin, and so on and so forth, ethanamide. So these are the other drugs which you can use, but please involve your infectious disease people, and then get it their advice, whatever available, wherever you are working, you can use it. In most of the resistant, when in the USA, the resistant tuberculosis is high, so we use moxifloxacillin or levofloxacillin in most of the cases. Sometimes in New York, we use with ethambutol or pyrazinamide. So because New York is very high prevalent in the resistant tuberculosis. If we suspected the pulmonary and extrapulmonary disease except the meningitis, then this is the regime: the 2 month of rifampin, INH, pyrazinamide, and ethambutol. We called it RIPE, daily or 3 times per week, followed by 4 months of INH and rifampin by those medicine which we call dog for the drug susceptible mycobacterium tuberculosis. If you have a meningitis, then you have a INH, rifampin, and pyrazinamide. So these are the different regime we should use, and then I think all those medicines are available in Pakistan. So I don't think so is any problem in having that. These are the different drugs, different doses, but you can either use this reference or any other reference, but I think most more or less it's a similar kind of a range. Now come to, this is the general idea. I think tuberculosis, you can talk more and more, but this is just a basic, you can have it. So at least you are in the safe side if you know that much about that. Now the torch infection. Torch, as you all know, is the toxoplasmosis. Others like syphilis, varicella, parvo B, hep B. R is rubella, C for cytomegalo, and H for herpes simplex. I found this one article which is published in 2018 from Khyber Medical University from Peshawar, that the frequency of torch infection during pregnancy in Peshawar, and they mention it is about 7%. With the toxoplasma is 2.5, rubella 1.5, cytomegalo 1.8, and herpes simplex 1.1. So I don't know if this is the model for all other provinces or in all other cities, but 7% torch infection is on the higher side, except in the southern America, like Brazil, Argentina, where the prevalence is higher, but all other part of the world is around, I mean, in Middle East and Europe and USA is about 5%. So this is one article I found it out. The other thing, the another article which published in 2011 by Dr. Bhutta and his group, Dr. Sidra is the main author, and they also mention is they actually want to find it out the effectiveness of intervention to screen and manage infections during pregnancy on reducing stillbirth. So what they mention is potential causes of stillbirth, including HIV and torch infection, need to be investigated further to help establish the role of prevention treatment and its subsequent impact on stillbirth reduction. So they are also mentioning about the same, that we have to screen and we can prevent those stillbirth. So these are the two articles. If you interested, please review those. Now, screening for torch infections. So what is going, we are following the USA guidelines. So what are the screening during pregnancy? We are doing the practice of screening in the United States by the American College of OBGYN. ACOG recommend that pregnant women may be screened for rubella and syphilis at the first prenatal visit. In UAE, we are not doing the syphilis, but the rubella. Okay, so that's the difference. But I think in Pakistan we should do both rubella and syphilis. Newborn screening, asymptomatic infant generally are not screened for any congenital infection. But let's say if there's some infection, baby is presenting with some kind of a typical, we will go through it, typical some sign and symptoms. So then we should review and we should screen the babies. But routine in, screening for the newborn we are not doing, but for the mothers we are doing. So first infection in the torch complex is the torch, is the toxoplasmosis. So this is disease caused by the intracellular parasite Toxoplasma gondii, the human acquisition of the infection by oocysts, contaminated soil, and ingestion of the raw undercooked meat containing tissue cells. So this is very important. So the areas, for example, like Peshawar, where they are more eating the barbecue or the prevalent of eating the meat cooked on the coal, the chances those meat is not cooked very well. That's why I think they did this study in 2018. But anyway, this is just my thought. Unpasteurized goat milk. I think I don't know, but Vikram maybe knows that it is used in our rural areas. But here in UAE, yes, they use in the rural areas the unpasteurized goat milk. The incubation period is approximately 7 days, and the range is about 4 to 21 days. So these are the just the cycle or the life cycle of the Toxoplasma, that it is go from the feline to the some animals, and undercooked meat, undercooked vegetable, and go the oocysts go to the mother, and then so on and so forth. So the primary maternal infection in pregnancy, infection rate higher with infection in the third trimester. So the infection rate is very high in third trimester. So that's why we have to be very careful when we eat the vegetables, and the meat should be properly cooked. Transmission, how it transmit is vertically transmitted, can occur in the utero. So as I said, 25% in the first, 75% in the third, and 90% during the last few weeks prior to delivery. So that's how it is, that it is in the later part of the delivery, the chances is higher. Transmission to the fetus from previously seronegative immunocompetent mother, reactivation of previously immune pregnant, or reinfection of a previously immune pregnant mother. So these are the clinical manifestation. If the baby get transmission during the first trimester, the chances of IUFD, intrauterine fetal death, is very high. CNS infection very high. Ophthalmology sequelae is very high. There's a classic triad in the second trimester. If you get it, then you can get the classic triad of hydrocephalus, intracranial calcification, chorioretinitis, jaundice, hepatosplenomegaly, and so on and so forth. And the third trimester, most of them are asymptomatic at the birth. So these are the signs and symptoms we just mentioned. So what are the classic triads? This is the rat cam picture of chorioretinitis. So it is in the severe form. So this is one of the triad, then the hydrocephalus, and the intracranial calcification, as you can see here. In the end stage, when the kid become very sick, is the very big hepatosplenomegaly can occur, and then it is very difficult to treat this infection. So how to evaluate it? A review of maternal history. So that's why very important, but I don't know if they are doing the evaluation of the toxoplasmosis there. But if you are suspecting, just take a proper history, proper diet history, and so on and so forth. Assessment of physical stigmata consistent with various intrauterine infection, complete blood count, liver function, radiograph, ophthalmological evaluation, audiological evaluation, neuroimaging, and lumbar puncture, and all those we have to do in the babies. So the serial IgG measurements for maternal infection, amniotic fluid PCR for fetal infection, and serological testing, brain imaging after the birth, and the PCR testing, especially the CSF. So how we confirm it? If the detection of Toxoplasmosis IgM after 5 days of life, or IgA titer is after 10 days of life, is considered diagnostic of congenital toxoplasmosis. Positive for Toxoplasma IgG beyond 12 months or positive CSF PCR increase in anti-toxoplasma ID titer is during the first year of life. So all this, if it is thing, then we said it is a congenital toxoplasmosis infection. So it's a busy slide, but if you go through with me, then it is easy that how we treat it. So in pregnant women with an established recent infection, spironolactone 3 gram daily in divided doses should be given. In babies, you start with pyrimethamine at dose of 1 milligram per kg, administered twice daily for 2 days, and then once daily for 6 months, and then 3 times per week to complete 12-month total course of therapy. So it is a big duration of treatment. Plus pyrimethamine, you have to add sulfadiazine at a dose of 50 milligram per kg, again twice a daily for 12 months total, and you should use folinic acid. Folinic acid and folic acid is the same. It's a vitamin B9 group. Folinic acid is an active form. Folic acid is a synthetic form. That's the only difference. So if you have a folinic acid, fine. If otherwise, you can use the folic acid. So at a dose of 10 milligram, 3 times per week to complete 12-month total course of therapy, folinic acid is used to minimize the pyrimethamine toxicity. Folic acid may not be substituted for folinic acid, but it is because of the pyrimethamine toxicity, you need some active B9, not the synthetic one. But if not available, I think you can use the folic acid. But I think folinic acid is also available in Pakistan. If the CSF protein is more than 1 gram per deciliter, the severe choroiditis, then the recommendation to use the prednisone as a dose of 0.5 milligram per kg, maximum 20 milligram per dose, and administer twice daily until the CSF protein is less than 1 gram per deciliter or resolution of choroiditis. So these are the regime which we are using in our babies here. Some European countries, Germany has some different regime, but these are the things. But I put it here. They are using pyrimethamine and sulfadoxine every 10 to 15 days is used for subclinical mild form of congenital toxoplasmosis. But I think we should stick with this the recommended regime. Next, I want to talk about the syphilis. Syphilis, you know, that is a Trypnea pallidum, is a spirochete bacterium with a various subspecies. It is transmitted only among the humans, so this is specific for this organism. It is like a coil, helical and coil. Route of infection is direct contact with the spirochete containing lesions sexually or transplacentally. And it is happening commonly, especially in USA, especially in the New York. The incubation period of acquired primary syphilis is about 3 weeks, but rate from 10 to 90 days. Transmission is human are the only natural host for that. So congenital syphilis generally is through the placental transmission, and it can occur at any time during the gestation. It's not like toxoplasmosis that the higher in the third trimester. Women with untreated primary or secondary syphilis are more likely to transmit the syphilis. The risk of transmission decreases with increasing time. So that's another peculiar thing about that. T. pallidum is not transferred in the breast milk. So again, so no infection is contraindicated for breastfeeding, but transmission may occur if the mother has infection and lesion on her breast. So of course, this is true for anything. But if there is no lesion on the breast, then you can easily ask the mother to feed the baby. These are the typical signs and symptoms. Early congenital syphilis, 1 to 2 month, macular rash, snuffles, generalized lymphadenopathy, thrombocytopenia, chorioretinitis, meningitis. Late, more than 2 years of age. If you are suspecting the syphilis, then examine the placenta, because placenta of neonate with congenital syphilis is often large, thick, and pale. The umbilical cord is edematous and may resemble the barber's pole. Barber pole, you see the barber shop has this blue and red and white pole. It looks like that, with the spiral stripes of red and light blue discoloration alternating with the streak. So you can see the barber pole. And it is very typical. I saw myself many syphilis patients with this type of umbilical cord. Later on, this is very typical. If you have a rash in the soles and the palm, like this, please, if you couldn't find in the history, but then you raise your suspicion of syphilis, which is very typical. These type of rash, very few disease has the rashes like this in the soles and the palm. So this is one of the presentation. This is the maculopapular rashes in the palm and the sole, which can the syphilis. You all know about the sniffles. This, then the later part of the life is the teeth and all those saber shins. You all know about that. How we diagnose it? Dark field microscopy. This is the most common. It is the most specific technique. It shows the appearance as I showed you in the first slide. It's like a corkscrew or helical appearance. Negative exam on 3 different days are necessary to consider the test is negative. So you have to do the 3 tests before you said that it is negative. Direct fluorescent antibody in fluid from a lesion, the placenta or umbilical cord is another way to diagnose it. Now, the presumptive diagnosis, and this is always very confusing. So there are two types of the test: the non-treponemial test and the treponemial test. So syphilis lead to the production of non-specific antibodies. Remember, the non-specific antibodies that can react to the cardiolipin, and the quantified by serial serum dilution. So the VDRL, or the venereal disease research laboratory test, or the rapid plasma regain is used. It can be false positive, as for example, pregnancy, autoimmune disorder, infections. Sorry about that. False negative, early primary syphilis, late syphilis, prozone effect also. Treponemial test also can be false positive and false negative. So that's why we have to repeat the test, and at least 3 test negative, and then we can call these negative. Maternal screening and treatment. All pregnant women should be screened. This is the recommendation in USA. The recommendation here in UAE is different, because they think that sexually transmitted diseases are not that very common here in UAE. So here they are not recommended to all pregnant women. But in Pakistan, I think we should do the screening the all women. If infected, it has to be treated by penicillin G. Follow up with the non-treponemial test and treponemial test every 4 weeks. Screen the infants if the mother has titer that increase the fourfold, or positive test without documented treatment, not treated with penicillin. This is very important. No other antibiotic is considered as a treatment for syphilis except the penicillin. So if the mother is treated with, let's say, some other antibiotic, uh, it counts as a not treated. Okay. So the treatment less than 4 weeks prior to delivery also counted as a not treated. If sign of congenital syphilis, as we discussed, then we have to do all these tests: CBC, liver function, ophthalmological exam, and so on and so forth. So, what is the meaning of inadequate therapy? Treatment with non-penicillin antibiotic, treatment less than 4 weeks before delivery, inappropriate dose for these stages of the disease, inadequate documentation of maternal treatment, and inadequate response to therapy means maternal not treponemial antibodies did not decline at least fourfold. So this is very important tables when you are treating the babies, that what is the meaning of different thing, and how you proceed, and how you plan your management. Again, There's a very simple algorithm. It looks very complicated here, but it is a very simple algorithm. If you go through it, and it guide you very simply. The treatment option is the aqueous penicillin G 50,000 unit kg intravenously every 12 hours for 1 week of age, or every 8 hours if it is more than 1 week. Or you can give procaine penicillin 50,000 unit intramuscularly as a single dose for 10 days. If a 24 or more hours of the therapy is missed, an entire course must be started. So this is the most important thing. And then you go through it that if it is false positive, what to do. If it is false negative, what to do. And then you read this thing. And this is the key for this algorithm. So this is a very simple algorithm. It is very latest from the American College of OBGYN and the Red Book. And I will send it to you, so you should go through it and keep it in your library. Uh, One thing I tell, if my junior colleagues, if my postgraduate students, these infections, maybe I don't know, you are familiar or not, or you are seeing in your practice, but if you are giving any postgraduate exam, they are asking many questions about those infections. At least in the American exam, like USMLE, American Board of Pediatrics, American Board of Neonatology, they are asking a lot of questions from these things. So not only for your practical purposes, for your knowledge and for your educational purposes, these things you should keep in your mind. The rubella, the German measles, is a 90% chance. So that's why all the mothers should have, and it is a very severe infection. So the chances of intrauterine death is very high. So we have to do the screen in all the mothers. It is looks like that. It is not the coronavirus, but it looks like it. It is also the RNA virus. It's a member of the Toga virus family, contact with respiratory secretion, and the transplacental it goes. It's 5 to 7 days after the maternal inoculation. The transmission infection with rubella virus is referred to a congenital rubella infection, or CRI. Infection with rubella earlier in pregnancy, like first trimester, has worse prognosis. So if the baby get it in the first trimester, the chances of death is very, very high. The virus can become transmitted to the fetus, to the placenta, as we all know, and the incubation period is about 14 to 21 days, usually 16 to 18 days. There are a lot of complication. So if a less than 12-week gestation and the mother get the infection, then often results in congenital defect, greater risk in first 10 days of gestation. More than 12 weeks have no clinical manifestation, more likely to result in future hearing loss and visual problem. Sign and symptoms is a very typical, which we called it blueberry muffin rash, which is dermal erythropoiesis. As you can see, it looks like a blueberry muffin. If you all know about that. Lymphadenopathy, hepatosplenomegaly, thrombocytopenia, IUGR is very important, and meningoencephalitis. Now, there are some manifestation, their frequency, and what happened. Okay, so if the hearing impairment, the chances is 60%, and this is a permanent. So that's how the morbidity of this disease is very, very high. Again, it has a typical triad in the newborn period. Microcephaly can happen, PDA, and the cataract. Okay, so the hearing loss is permanent, intellectual disability is permanent, diabetes mellitus can happen, thyroid dysfunction, and progressive panencephalitis. So these are the frequencies: hearing impairment, heart defects, and patent ductus arteriosus. So this is a very common question in many of the exam about the clinical manifestation of rubella. They give different congenital heart disease and which one is the common of that. Uh, I just want to mute. I have to answer this. Just 1 minute. I will, and then I will. I will back. Just 1 minute. I will be back. Uh, Hello. I have to answer that phone call and we will start again. Sorry about that. So anyway, antenatal detection is the same specific IgM in fetal blood, rubella antigen in and the RNA in chorionic villus sample. Postnatal detection to confirm IgM below 3 months or IgG below between 6 months to 12 months. Of course, with this infection, we don't have any specific management. You just give the supportive care, no role for antiviral therapy. So don't spend a lot of money on the antiviral therapy. Multidisciplinary approach. Main problem is the hearing loss. So the hearing aids and refer to an early intervention program. Structural cardiac defects, if needed, then surgical correction, ocular abnormalities, CNS abnormalities. So these are all supportive, and this is a multidisciplinary team approach. We don't have any specific therapy for CRI. Prevention we are doing, girls should be vaccinated again, rubella before entering the childbearing age. So all the girls in the school in USA and the UAE, they are vaccinated. I think in Pakistan also they should do it. Rubella vaccine is a live attenuated, which is available separately or as a triple vaccine like MMR. MMR, I know it is given in Pakistan immunization schedule, but at school age, like 14, 13 years of age, we give extra vaccine of rubella. So AAP recommendation, 2 doses of MMR, first at 15 months and the second at 4 to 6 years, and then at the the childbearing age. A special care would be taken in reproductive female to avoid pregnancy for 3 months after MMR vaccination. As I said, it is the live vaccine and avoidance of exposure. We'll go through, Vikram, we have time or we can do it,
We
or
have
I
10
can.
minutes.
10 minutes. So you want me to jump to the hepatitis B because I want to show the hepatitis B. I think it's better, huh?
I think we can go through it in short. Uh, Decide on yourself.
So, okay, I will go through the hepatitis and varicella, okay?
Okay.
Varicella I want to show, and then hepatitis B, and then I will finish because there are other infections also, but as you know, there are too many things and too much information. So varicella zoster is another herpes virus, is a very common route of infection, is contact with the fluid from vesicles. Congenital varicella is acquired transplacentally. Time of diagnosis less than 20-week gestation, the chances of fetal demise, and all those ophthalmocutaneous limb hypoplasia, CNS damage. Later gestational, typical signs of varicella after birth or maybe asymptomatic. So the cutaneous scar, which may be depressed and pigmented in dermatomal distribution, cataract, chorioretinitis, hypoplastic limb, all that can offer. How you should diagnose? It's a very obvious. You can see the chicken pox rashes, PCR or direct fluorescent antibodies or IgM titers. You can do it. How's the management? So if this is very important, that's why I want to tell all of you, if the newborn with severe disseminated VZV infection are treated with intravenous acyclovir 30 milligram per kg in 3 divided doses for 10 days. Antiviral treatment must be started as soon as possible after the onset of the symptom because most viral replication has stopped by 72 hours after appearance of the rash. Okay, this is breastfeeding. Whether VGV is secreted in human milk is uncertain, although the varicella zoster is a DNA virus. So remember, all the herpes, all the hepatitis viruses are the DNA viruses. Has been detected. Breastfeeding is encouraged in newborns. Okay, so there is no such thing that you should stop the breastfeeding. This is important, that management of exposure. So the management of newborns who are exposed to this infection by maternal infection or contact with affected individual includes isolation and post exposure prophylaxis. The specific intervention depend upon the timing of exposures, okay, the mother's serological status and gestational age. Varicella vaccination, yes, we are doing it. It is in our schedule. I think it's also in our Pakistan also. The post-exposure prophylaxis is we are giving called VZIG or VeriZig. It's an immunoglobulin. It's called varicella zoster immunoglobulin. And when to give it, I will tell you. If it is not available, then you can use the IVIG. So the American Academy of Pediatrics, the CDC, the Central Disease of Prevention and Advisory Committee on Immunization Practice, ACIP, recommended administration of VZIC to newborn who have had significant exposure to varicella plus one or more of the following. So what is this? If the mother symptoms, neonates whose mother have sign and symptom of varicella around the time of delivery, within 5 days before or 2 days after, it should receive the Varizic. If you don't have this, then you can give the dose of IVIG. Preterm infant, if it's more than 28 weeks of gestation, then the recommendation is hospitalized preterm infant born than more than 28 weeks of gestation who have a significant exposure to varicella zoster and whose mother do not have documented immunization, serological immunity, or prior documented history of varicella infection should receive the VZIG. Infant less than 28 weeks, regardless of the mother history, should receive the varicella zoster immunoglobulin. Healthy term neonates who are exposed to varicella postnatally generally do not require any prophylaxis. This is because postnatally acquired varicella is very mild and it will go away. However, some experts suggesting administering VZIC in this setting also, but we are not doing it. VZIC is an intramuscular at a dose of 125 unit, one vial for neonates weighing more than 2 kilogram. If it is less than 2 kilogram, you can give the half vial, which is 62.5 units. When post-exposure prophylaxis is indicated, passive immunization with VZIC should be offered as soon as the possible. So it's a similar kind of a thing what we are doing for hepatitis B. The efficacy is its efficacy is inferred from observational data demonstrating considerably low transmission rate and milder disease as compared to not giving it. The supporting evidence is discussed in greater details in many other articles. So the VZIG is unavailable. Then, as I said, IVIG or prophylaxis with acyclovir can be considered. But most of the time, we are having the VZIG first of all. If not, then some center uses IVIG, which is also very effective. Hep B, there's some new thing I have to tell. This is the global prevalence just published in 2021. And as you can see, we are in the dark gray. The dark gray means is about the 2% to 4% of the hepatitis B prevalence congenitally. Hepatitis B is a DNA virus. It's a family of hepatitis virus. It has many things, which is the surface antigens and E antigen or the core antigen, which is the inside or the core. So we have to understand that. Why I'll show in a minute. Transmission can be happen perinatally in utero transmission for less than 2% of all vertically transmitted HBV infection. In most of these studies, 70 to 90% for infant born of the mother who are HB surface and HBe antigen positive. Uh, The incubation period is about 45 to 160 days, an average of 90 days. So diagnostic tests for this is, these are the tests we should do: anti-HB surface antigen, anti-HBs. What is the meaning of that and how we interpret it is all this in this table, and we are, you can go through it. But the most important thing to understand that when the all these type of the antigens and antibodies increase, so this is the titer and this is the post exposure weeks. So total anti-HBC, which is the solid line, okay, and HB surface antigen, which is the dotted dash line. The dotted line is IgM, and the anti-HBs is the dot and the line. So first of all, the HB surface antigen increase, go peak about 12 weeks and then come back in 24 weeks. This is the HBe antigen and this is the anti-HBe antigen. You can have it. If somebody get infection, so this is the scenario is changed. The HB total anti-HBC continues for years. HB surface antigen is also continue, and IgM increase at 6-7 weeks, and then go peak about 16 weeks, and then come back to normal about 36 weeks of age. So the goal of the treatment in chronic HBV infection is to prevent the progression to cirrhosis, because we don't have the treatment. Yes, there are some antiviral, but they are not as effective as. So current indication for treatment of chronic HBV infection include evidence of ongoing HBV viral replication. Uh, and the presence of, so as indicated by the presence of no longer than 6 months of either serum HBV DNA greater than 20,000 international unit, or elevated serum ALT. Treatment response is measured by biochemical responses, as I showed you in the graphs. So these are the hepatitis B immunoprophylaxis. So two type of the prophylaxis we have: HBID, which is the short-term protection, and hepatitis B vaccine, which is the long-term protection. Breastfeeding of an infant with HB surface antigen positive mother poses no additional risk of acquisition of HPV. So again, in all those infections, you should continue the breastfeeding. So this is the algorithm, very simple. If the mother is HBs surface antigen positive, all newborns at all birth weight, hepatitis B vaccine and immunoglobulin within 12 hours of birth you should give. If the mother is HB surface antigen negative and birth weight is more than 2 kilogram, then hepatitis B vaccine within 24 hours or before discharge you should give. If it is birth weight less than 2 kilogram, then hepatitis B vaccine at 1 month of age, let's say 24, 25, 26, 28 weeker, it stays there. So you give at 1 month of age and then you repeat it again. If the mother antigen is unknown, this is the most of the time it happens when the mother has no antenatal care. All newborns at all birth weight, we give hepatitis B vaccine within 12 hours of birth. We send the mother titer and then we wait for that. If birth weight more than 2 kilogram, then hemo uh, HBIC within 7 days of birth if maternal status is confirmed positive, or by 7 days of life or at hospital discharge. HBIG within 12 hours of birth unless maternal status is confirmed negative by that time. So that's how it is. So less than 2 kilogram baby, if you have to give vaccine and the HBIG if the mother status is positive within 12 hours. If the mother status come negative, then it is negative. For full term, more than 2 kilogram baby, you have 7 days to give immunoglobulin. The follow-up of these babies are very important. So infant born to HB surface antigen positive women should be tested for anti-HBs and HBs surface antigen at 9 to 12 months. Testing should not be performed 9 months because it to maximize the likelihood of detecting late onset HBV. So let's say if you did the test and you find it out more than 10 ml, 10 micro international unit per ml, and who are HB surface antigen negative are considered not to be infective and to have adequate vaccination. Infant with anti-HBs concentration less than 10 and who are HB surface antigen negative following a 3 dose of hepatitis B vaccine series should receive one additional dose, and then you should repeat the titer again 1 to 2 months after the fourth dose. So the titer should be more than 10 micro international unit per ml. Infant with the anti-HBs concentration more than 10 ml and whose are HB surface antigen negative after the fourth dose are considered to be not to be infective and adequate. An infant with anti-HBs concentration less than 10 and who are HB surface antigen negative after the fourth dose even, then you should again give 2 additional doses separated by 8 weeks, followed by the testing for anti-HB surface antigen 1 to 2 months after the sixth dose. So that's how we continue to monitor the titer and to give the doses of vaccine. And I think this is going to be the future for coronavirus also, that you should use your titer, should do your titer and give the and take the booster dose. This is, I think, is coming very soon. Anyway, an alternate approach for children who have completed a 3 dose of hepatitis but did not receive the titer is to give the 3 additional doses. So this is the alternative approach, the thing. So that's how you follow up. Just keep in mind the number 10. The concentration of the titer should be more than 10, and then do accordingly. This is just different infections, sign and symptoms, just for your information, for your examinations, if you are interested that which are the more significant infections in different sign and symptoms in different infections. I should stop here. I skipped few of the infections like herpes, like hepatitis C and HIV. As I told initially that HIV is a whole lot of things to discuss about. If you want, we can do it in separate talk. With that, I will take a lot of time of yours. Thank you very much to attend this and listen this very uh, patiently.